Assalamu alaikum. Today we will be discussing some points about breast surgery. Our discussions related to basic sciences topic will continue, but I just thought to in between we will be discussing some cases which I have not done in that way before. So in the due course of time, we will be discussing some other important uh, surgeries which we all of us encounter. So, um Tayyab, can you take the lead? Uh, what are usual breast surgeries which are being performed?
Uh, Thank you, sir. Mostly fibroadenomas,
Okay,
and other is CA breast,
okay,
MRM.
okay.
Uh, Only these we have assisted in our
Like
setups.
all these surgeries which you have talked are usually related to mastectomy or lumpectomy. Okay.
Okay, sir.
So what else? What else can be there?
Abscess drainage.
Okay.
Sure.
What else?
Uh,
Like lumpectomy, mastectomy. Like mastectomy, maybe simple mastectomy, or can you mute your mic, please, Tayyib? Yes, MRM. Okay, and with the axillary dissection. Okay, so as you told, in CN drainage, what else? Yes, Tayyib.
Sir,
What about breast reconstruction,
okay.
like mammoplasty? It
Oh,
may be reduction, or it may be with the placement of implants, tissue expanders. Okay. So there, and in this area, there are also some flap reconstructions, flaps, free flaps, not only free flaps, but also rotation flaps with latissimus dorsi and things like that. I'm not very expert in it, but like these are the things which whenever you are thinking about breast surgery, so you should be thinking about it. For instance, if we just focus on CA breast, for example, so what do you think? What will be the concerns in CA breast? Anyone else who wants to speak out? Otherwise, Tayyib will continue. Whosoever wants to speak out can just raise the hand, please. Is it our hero Osman? Which Osman is this? Is it okay? So, anyways, so I will continue. So, if, for example, if we think about CA breast, so there will be concerns related to the local spread, okay, and distal spread, maybe in the bones, in the lungs, liver, lungs. Okay. So of course, whenever you are the word CA breast comes, maybe it is not metastatized, but it may be. But local spread still will cause some problems, like it is in the axillary lymph nodes, for example. So it can cause edema in the limb. Okay. So you will be avoiding IV lines on that side, or even EP cuff on that side. Okay. If some of you keep on interacting, it will be very good. Yes, brain I missed. Okay. So these will be things. Then, for example, with relation to treatment, it may be chemotherapy, it may be radiotherapy, okay, and of course, surgeries. So it will be series of surgeries. So if we just think about chemotherapy, so chemotherapy will have problem with the bone marrow, cell lines, cardiac, renal, even liver dysfunction with certain chemotherapeutic agents, especially cardiac depression. So you have, whenever they are starting, they have a baseline echo, and later on they just compare it, so that if, for example, after starting of chemotherapy, if subsequently there is some involvement of heart, then they can follow it. Similarly, bone marrow. So bone marrow in the form of cell lines, okay, aplastic anemia, neutrophils, and like whenever you are looking at it, so you have to expect there may be anemia, or there will be involvement of other cell lines. Okay. So now only you are dealing with breast surgery. So whenever they are telling you we have a mastectomy, you should be probing it. So where it is spread, so you should have pan CT or whatever source. Of course, you are not the primary physician, but you should be knowing what is the extent of the tumor, what is the extent of the cancer, and is it involving anything? Does the patient receive any radiotherapy or chemotherapy? Radiotherapy, usually it will be causing scarring and everything. So if you are planning for some regional blocks, as the chest wall blocks, this will be a problematic, because the anatomy may be distorted. Okay. So of course, if there is a previous surgery and it is reoccurrence, so it may be more complicated. Okay. And during the procedure, what complications can occur, we will just shortly have a look on that. But usually this is before you are dealing with a case for breast. Of course, this will be one part of it, surgical part, the sorry, disease part. And then the surgical part, what are they doing? And if any other co-demographic or comorbidities, so you will be correlating together. Okay. So this is related to the carcinoma, radiotherapy, chemotherapy, involvement of bone marrow. And if, for example, there are metastases in the bone, so you may expect, you may need to have very careful manipulation of the patient, because maybe pathological fractures can occur. Okay. Pathological fractures can occur, and you have to be careful while placing the patient, shifting the patient. You need to be careful. Similarly, one aspect of cancer, that is pain. Okay. So maybe these patients will have severe pain, and whenever there is pain, so they maybe have opioid addiction. Oh, sorry, opioid dependence, not addiction. So opioid dependence. So whenever such patients come, you have to see whether these patients are on any opioids. Okay. Of course, maybe or maybe not. Not everything will be there in every patient, but you have to open up your eyes, and you have to look into the things that whenever there is a breast surgery, you should be looking on these things. So whenever there is a patient who is already on opioids, so you have to keep, I become very distracted with this. So I request you to mute your mics, please. Okay. So you will be looking at what is the baseline requirement. So if it is oral, you have to convert to IV. Okay. And then according to the surgery, or according to the acute pain, now you may have to add up analgesia. Okay. So you have to replace the baseline, converted oral to IV, If it is some other opioids, you should be knowing what is the interconversions of opioids, okay? And then you will be replacing it, okay? So this is an important part. Pain relief will be very important. And then when in addition to other, because I will be covering the analgesia part later on. So other things that whenever they are doing surgery, so there may be like preoperatively, they in addition to other thing, there may be involvement of brachial plexus, or in the, if it is in the axilla, it can involve. So there may be some, so you have to look at the involvement of brachial plexus plus minus. So you should be knowing about it. So this is one thing. And another thing is that sometimes when they are removing, especially extensive dissection or extensive involvement, you have to be prepare that maybe when they are doing extensive dissection, there may be involvement of pneumothorax. So whenever you are doing such case, you should be mentally, physically prepared for these things. If anyone wants to add, except for analgesia and the important, some of the important parts, anything I have missed, please just let me know. Because later on, I will just try to open some source, some. Is it Umar Malik, Umar, who just passed the exam?
जी sir, Umar ही हूँ.
Yes,
But sir,
okay.
I'm driving right now. I'm
Sure,
driving right
sure,
now,
sure.
so there will be a lot of noise.
No problem.
I'm just
But
listening.
if I have just, if you can just let me know if I have missed anything with reference to the breast surgery.
Uh, I don't think so, sir. You are going on the right path. I think so.
Okay, thank you. So I think, except because analgesia I had covered a number of times before. So my aim was to just have a look on these aspects before going to the analgesia part. Okay. So just a second.
Sir,
Yes.
transfusion related issues.
Yes. What are transfusion related issues?
Sir, what I have read, it is that sometimes if transfusion is not necessary, for example, HB is not too low,
Mhm.
transfusion can cause recurrence of
Recurrence.
action of carcinoma.
Yes, I just missed this thing. And another thing, it slipped out of my mind again. Yes, phantom limb. Okay, phantom limb pain. Mastectomy is one of the surgeries which are involved on this thing. And as mentioned, that any cancer, not only breast cancer, any cancer, it is not very advisable to transfuse too many because it is involved with the recurrence of the cancer. Okay. So if the patients are what you say, compensated, you should not give too much blood transfusion. Okay. So similarly, because some of the surgeries, other than breast carcinoma, there are some other things. But usually, these are the things which actually I just wanted you to know. So because it's not something too complicated. You should just be thinking what are the possible things, and actually the things which I have told you related carcinoma. This is valid for any carcinoma, any carcinoma. Okay. So just like we do any carcinoma, number of things will be alike. So if you understand this thing, you can use it in any other carcinoma, except for the things related to the location. Like for example, if there is airway cancer, any carcinoma which is involving or near to the airway. So that will be an additional thing. Otherwise, it can, all of them will have almost a similar effects. So you can have a look on some of the chemotherapeutic agents, you see, cyclophosphamide, doxorubicin, and their involvement in the like QT interval cardiomyopathy. And they have read about it. So they have a baseline echo or ECG, okay, so that they can track any change. And of course, you see, I missed one thing. This, thank you very much. Venous thromboembolism. Carcinoma is a prothrombotic condition So there will be chances of embolism. So you have to think about the thromboprophylaxis. Similarly, if there is high risk, there may be some involvement in the clot so in such patients there may be there are some filters, IVC filter, or so you should be thinking about these things. Okay, I'm just having a look on anything which I have missed. Mm, yes, with reference to
Sir,
free flaps, like in any free flap, you have to taking care of the with reference to free flaps, I will tell few things that whenever you have any flap surgery, so you have to maintain the viscosity. Okay. If the viscosity is going too high, the flow will be decreased. So you don't want flow to be decreased. Then you have to avoid vasoconstrictors. Okay. Then you might need to have oxygen therapy in certain, of course, with reference to high inspired oxygen, or going more, you might need to have some hyperbaric oxygen therapy in case of certain things in certain scenarios. So usually whenever there is free flap with not on reference to hair, you have to maintain the good perfusion. So because whenever if there is sympathetic stimulation, okay, so any factor which can decrease the blood flow for the flap, you have to be careful about it. Okay. So viscosity mean like you have to maintain around 30 to 33. And previously, even they used to have, no, nobody, I don't think so. They use it now. I don't see anyone using it, but Dextran is one of them. So they used to use Dextran, which cause platelet dysfunction, and actually they use it for the betterment of the flap. Okay. So again, I'm repeating, these are common things. So whenever any flap, you should be thinking about these things. And of course, if it is in a position that it needs to be immobilized, so if the patient moved, so all the efforts will be distorted. Also, temperature. You have to maintain normothermia. If there is hypothermia, again, platelet, there can be problems with the flap. Okay, so normothermia you have to maintain. So I think okay. So now comes the last part, which I will just try to, because this topic I had discussed multiple times before, so it's sort of repetition. So I will share the link of the discussion which I had done before. So yes, we will have a look on the analgesia part. So because as I told you that one of the factors for chronic pain is not corrected or not well controlled acute pain. So you have to be very careful that this is one of the surgery which is notorious for chronic pain, especially after mastectomy. It's a very big psychological trauma. So this is so in some centers when they are doing the mastectomy, sometimes they are doing the reconstruction as well. Okay, so like they are putting the implant in the same go. So this is also happening in some parts of the world, of course, according to the patient scenario. So just in narration, usually because if you think about choose the options for analgesia, so actually you should be knowing something about the innervation. So actually it is from the intercostal nerves. So that's some words about it is from the anterior and lateral branches of second to sixth intercostal nerves. There may be some variations of one of two level up or down, usually one level, and nipple level is around T3 to T4. So this is the simple. So now there are different options you can, and then the some of the part in the axilla will be from the T2, and some of the level up will be from the cervical supraclavicular nerves. Other important, which are upper pole of the breast, the intercostobrachial nerve, which is a part of second thoracic nerve that supplies part of axilla related to axillary tail of Spence and axillary lymph node. So you should be knowing what is the nerve supply. Okay, so multimodal analgesia, opioids, paracetamol, NSAID, gabapentin, I will not go in details of this at the moment. So what will be the options for regional anesthesia? So in regional anesthesia, you have one option, epidural. Okay, you can place the epidural around T3, T4. So you will be covering the area between T2 to T6. So one of the option. Other option is paravertebral. So it will be given at least 1 to 2 levels. And other option, now these days they are doing more of compartment blocks. And there is one other option which is actually modification of paravertebral. I would say that's in that scenario, that is erector spiny block. So erector spiny block is because the medication when we are spreading, it is spreading to the it is migrating to the paravertebral space as well. So uh, there are different studies which have been done, and according to the different scenario, you will be using any of these regional anesthesia techniques. But the compartment blocks, the PEX blocks are more preferable these days because it's simple and they are very effective in giving a good analgesia. Here they have put the all of the names. Okay, so I will just, you see, usually PAX 1 block is done between pectoralis major and minor, and it will be targeted at lateral and medial pectoral nerves. So actually the compartment blocks, the UL theme is that compartment blocks is not blocking any specific nerve. It is with high volume and it is in a compartment, facial compartment. So you are relying on the spread. So sometimes if because of you are not able to identify, and especially for example, if there is old age, with the not very well defined muscles, so you might inject the medication in wrong plane and it is not blocking. So it is possible. So that's why it is not used wholly solely as an anesthetic agent. It is given before the surgery to cover the intraoperative pain, and in some scenarios maybe post-operative, because post-operatively all the anatomy will be distorted. So they can put wound catheters for post-operative pain, and you can give erector spiny block with the catheter or thoracic epidural for post-op pain relief. In addition to that, with patient control analgesia. Okay, so PAX 2 is between transverse this internal oblique and serratus anterior, and serratus anterior plane block is also done it in the mid axillary line at fifth or sixth. It covers dermatomes from T2 to 9. Even it is doing more extensive block. Okay, so Dextran now, because it has a lot of side effects, so it is not used now. Okay, uh, I don't think so. No, anyone is using Dextran now. Okay, so it was just a quick review of breast surgery. I will share this link with you people, so you can have a look on these sources. Okay, I think we have just cover age, early menarche, late menopause. This is the risk factor for CA, and then chemotherapeutic agents, risk of PONV. Of course, I forgot to mention about nausea, chemotherapeutic agent mediated nausea, vomiting, and actually this ondansetron, which we use a lot, ondansetron and granisetron. Actually, it was initially used for cancer chemotherapeutic related nausea, vomiting, and later on it was adapted by our anesthesia fellows as well. It is one of the most commonly used medication now. Okay, so they have put some words about the structure and advantages of regional: reduce PONV, opioid avoidance, superior analgesia, reduce stress response, like in any other surgery if you do. And disadvantages: there are chances of pneumothorax, there may be bleeding risk. It is actually also with reference to the surgery, some of them, and they have, because they have mentioned all complications related, disadvantages related to all these four techniques which they have mentioned here. Okay, so thank you very much, all of you. Any comments or any question or anything? Uh, Again, I tell you something, because the usual books which you read, you will never find such topics. And actually, practically, these are the things which you should be knowing. And these are the things which they will be asking you in the exam. So unfortunately, because our usual textbooks, they don't so-called, I will not ask them, textbooks, because none of the book is perfect. I have a, like, I am of a strong opposition of the people who are just worshipping one single book, and they become in trouble. And even if they pass the exam, they will never be a good clinician till the time they are able to correlate the whole of the picture. Like, you see breast surgery, if you want to read about it, from which book you will read? Just tell me. It is so multidimensional. We started from the presence of the breast cancer spread different. Maybe in some exam they can they may also ask about or different types. Okay, not really, but they can ask. And then later on, you should be knowing all the perspectives which I told, related to chemotherapy, radiotherapy, surgical excision, breast this axillary lymph nodes involvement, metastatic involvement, bone marrow, bone, liver, lung. So you should be knowing each and everything. You should be knowing about opioid replacements. You should be knowing about all the regional anesthesia techniques which may be used for such surgery. Okay. So thank you very much. Sorat, Dr. Sorat, if you want to comment something, your
Uh,
mic is on.
sorry sir, अभी join किया है. Sorry sir.
Okay. So thank you very much, all of you. So we will come back with some new topic, inshallah, soon. Thank you very much.